Hi, thank you for the opportunity to join you today. I am always so excited to talk with different networks and groups of researchers and practitioners about implementation science. And specifically today, I'm going to talk about learning from the dynamic role of context, and specifically using conceptual frameworks to guide implementation projects. And I'm going to be talking about the consolidated framework for implementation research that we refer to as the CFR, and then kind of taking off from there in a few different directions that I hope you find interesting and useful. So we have a proliferation of what works evidence. This is what I call evidence that is coming out of typical clinical or randomized control trials. So you can see how the graphs go up, and this ended almost 10 years ago is where this graph ends, but I know that the shape of the curves is continuing. And so we have a lot of evidence about what works in very controlled circumstances within a trial setting, but we don't have a lot of evidence about how to get that evidence reliably into practice, routinely and every time. We have persistent gaps in knowledge. This is just one example, looking at quality and safety teams in acute care. So this particular intervention is complex. It's got many different components to it, and the boundaries are kind of fuzzy, on what the intervention is versus the context and processes within the context that need to kind of interact or connect to the intervention. In this case, this is from a Cochrane review, and the authors concluded that findings revealed limited information about attributes of successful versus unsuccessful team initiatives, barriers of facilitators to team initiatives, unique or combined contribution of selected interventions or components of this particular intervention, or how to successfully establish these teams. So no wonder we have such a gap in what we know might best serve our patients versus what's actually delivered in the real world. Within implementation science, we embrace complexity. This means that we've got a lot of moving parts and a lot of variables, if you want to think of it in a quantitative sense. It is very challenging to kind of navigate our way through all of these different dimensions of complexity. And these 5 areas in terms of intervention, in terms of pathways of how that intervention works, population complexity, implementation, and contextual complexity. All of these 5 dimensions of complexity really are at play within implementation science. And it makes our work challenging, but also really exciting in terms of the possibilities and the contributions that we can make. I'm going to walk through an illustrative example. This is an evaluation that we did, that our team did, implementing a telephone lifestyle coaching program within the VA. And this is based on a large-scale pilot implementation of a program that was being delivered by an outside vendor. So this was a vendor who provided very high-quality coaching to help patients change lifestyle behaviors. We used a mixed methods approach in our case, and this is very common within implementation research, is that we're often combining methods. Quantitative surveys are rarely enough. They give us the breadth, but they don't give us the depth and richness of information we need to really effectively tailor our implementation approaches. We often draw on qualitative interviews like we did within this particular study. We use quantitative administrative data and qualitative field notes. In the case of this particular study that I'm going to highlight, we used all 4 sources of data. So the Telephone Lifestyle Coaching Program itself is a coaching program with 6 different topics that patients could choose to engage in. The 2 main, most common topics chosen were striving for a healthy weight, or in other words, really pretty much focused on weight loss, or being tobacco-free or smoking cessation. The program delivered up to 10 calls over 6 months by a centralized cast of coaches or network of coaches. There's a strong evidence base for the effectiveness of telephone-based coaching delivery to help people change lifestyle behaviors like weight and diet, physical activity that contribute to weight loss, and then for smoking cessation. Over 9,000 veterans were referred by 25 different facilities, medical centers that were participating in the pilot over a 19-month period. Over half of those enrolled. The loss between the number referred versus the number enrolled had to do with the inability to actually contact people, or maybe out of date phone information within the referral, et cetera. But of those who enrolled, the large majority actually completed a minimally effective number of sessions, which we kind of put a line at 7 or more sessions. So they had a high degree of participation once they were enrolled. What we found in the 19 months since the launch of the program during the course of this pilot is that the site with the highest rate of referrals had 7 times more referrals, or a higher referral rate, than the lowest rate of referrals. And this is despite the fact that, of course, it's the same program and the same system with the same level of support for everyone. And they really did receive a lot of different dimensions of support to help them in their implementation efforts. And on the surface, it seemed like this was a pretty simple implementation, because all the medical centers, all clinicians needed to do was to identify patients who would benefit from this program and then make the referral. They didn't have to actually deliver the program or set up the program itself. But again, despite the seemingly simple implementation that was involved here, we nonetheless still had differences on a scale of 7 times from the lowest to the highest. So our question was, what are the barriers, or what were the barriers and facilitators to implementation? And again, like I mentioned earlier, we used a mixed method study design. I'm not going to go into great detail about the source and the methods of data collection, but just to suffice it to say that we use quantitative data on the complexity of facilities, which is a score that we apply to medical centers within the VA that indicates things like size, whether they have an academic affiliation, the number of specialty services offered, the type of emergency care provided, and then also an assessment of readiness using the ORCA, which is the Organizational Readiness for Change Assessment by Helfrich et al. And we used a purposeful sample that maximized variation along these 2 axes. So we wanted to get high complex sites that had low readiness, and et cetera. We collected qualitative data by producing verbatim transcripts of stakeholder interviews using a semi-structured interview guide. We also did field observations during site visits. Some of our interviews were done in person via a site visit, and then we also did follow-up interviews by telephone. Outcomes. It's very important to conceptualize outcomes, and we want to identify an outcome that is as proximal to our implementation efforts as possible. In our case, we used a concept of penetration, and this is described in a paper by Enola Proctor and colleagues, who describe a kind of a framework of outcomes that are important for implementation. Our operationalization of penetration is the number or the rate of referrals. So when we think about applying a framework, I'm going to start with a metaphor. I enjoy playing Scrabble, but when I first look at a pile of letters, it can feel overwhelming. Luckily, I know my alphabet and I can organize letters in a way that makes sense to me. This gives me an organizing framework to help make sense of the letters I have. And the same is true for context. It can feel like an amorphous array of dynamics that are hard to recognize and describe, but like the alphabet in Scrabble, using a framework helps us to make sense of context. So frameworks help us to identify, articulate, and understand contextual factors that can influence success or failure of a planned implementation. So our kind of working meta hypothesis within implementation science, or to help us understand what one practitioner called it was the secret sauce for a successful implementation, is that we have an evidence-based innovation that we want to implement. There is sufficient evidence supporting its effectiveness through clinical trials usually. And we need to design implementation strategies to get good implementation outcomes that are an indicator of effective implementation. And we need both of those things, both an effective evidence-based innovation and effective implementation strategies to ultimately see system and patient outcomes, or the impacts that we want to see by having implemented the innovation. But we also recognize that this dynamic, this rather simplistic linear path is happening within an embedded context. And I'm going to go through each of these layers. But we know that patients and providers are embedded within clinical settings that all have different dynamics, different cultures, different processes. And then those clinical settings are embedded within system level or state level or national level settings. And context is a key moderator of the relationships between implementation strategies we use and implementation outcomes. And we also assess context to help guide adaptations of the evidence-based innovation itself. So the consolidated framework for implementation research is a determinate framework. And this means that it organizes, in the case of the LeaRRn, it is an organizing structure for over 30, well, I count 39, it just depends on how you count them, but 39 different constructs and subconstructs across 5 different domains. And what the LeaRRn does for us is it gives us language and labels and definitions and concepts that we can use to help make sense of the dynamic multi-dimensional context within which we're doing implementation. So this is a snapshot of, or a screenshot of one of the pages that shows just a bare hint of some of the constructs within the LeaRRn. And this is our technical assistance website. And I highly recommend, if you're interested in using the LeaRRn, to go to LeaRRguide.org. There really is a plethora of information to help guide you through use of the framework. And one of the things that is very important to note is that though I'm talking about the LeaRRn today, it is not the be-all end-all framework for every implementation project. There are many other frameworks too that have different lenses or different ways of looking at the world. And it's important to know and understand those, and then to choose a framework that brings clarity to your work and that helps to really advance your development of theory and your testing and refinement of the theories that are guiding your work. The LeaRRn is just one such framework. And the principles that I talk about today can be applied to any determinant framework. There's the Paris framework, the normalization process theory framework, etc. Now I'm going to step through each of the 5 domains within the CFIR. The first domain is the evidence-based innovations themselves. We know, and for those of you that have experience in doing implementation, or even if you haven't, there are all kinds of different innovations. There are pharmacotherapies, cognitive behavioral therapies, mobile apps, more and more e-health and m-health interventions and possibilities. Now we're moving more into artificial intelligence. All of these different innovations have different characteristics. What the CFIR does is it recognizes that the perceptions of key stakeholders are really important to assess before beginning implementation. So beyond just what kind of innovation is it? Is it a technology? Is it a behavior change, et cetera? We need to know, even within a technology type innovation, what are people's perception of, for example, the evidence, strength, and quality of that innovation? And here is an example quote. So I'm going to provide examples as I step through each of the 5 domains. This is one person, when we asked her what her perception of the evidence was for the TLC program, she said, "I was impressed with the evidence, and our own patients have been successful with a similar program." She's drawing on 2 different sources of information in this statement. One is, I was impressed with the evidence. This was coming from the scientific evidence base. The second part of what she was saying was coming from her own experience and knowledge and perception of her own patients. She's seen patients be successful in similar programs. So there's more than one source of evidence. Just because the scientific evidence may be strong, that doesn't necessarily mean that they're going to have a strong positive perception. And certainly we're seeing that these days with vaccinations, for example. So characteristics of individuals is another domain. We know that the perceptions of providers and patients about the innovation can really affect their use of that innovation, and therefore our level of success for implementation. One of the constructs, which is kind of a broad construct around knowledge and beliefs, here is one physician who said, it doesn't work, they regain the weight anyway. I've worked in clinics, or I've worked with clinics with this kind of culture that they're kind of reluctant to refer patients to a weight loss program because they don't feel like their patients are going to be successful. And this can be true of other topics as well. So this tells us, wow, we need to have some kind of an awareness or education strategy, some kind of engagement strategy to help flip the perceptions of these providers, because otherwise they're not going to refer patients to this program. The next domain, and probably the best developed in terms of the volume of constructs that are captured by the CFIR, is the inner setting domain. This is really where the action happens. This is where the micro-clinical kind of settings reside. It is where the implementation activities occur. And it's important to assess perceptions on these concepts. So for example, compatibility. What is the perception of key stakeholders, their assessment of compatibility of the new EBI, the evidence-based innovation, with their clinical setting? So here's one person who said, the health coaching just fits right in with our disease prevention and health promotion programs, and it's such a compliment. Now, I want to say that with all of these examples that I'm giving either a positive or a negative, but again, even though it was the same system, the same program, the same level of support for everybody, we had very different perspectives. So this person said that, it's highly compatible with our existing programs. We had other people who were on the other end of the spectrum in other medical centers who said, they felt like the program was going to compete or not fit with their existing programs. The next domain is the outer setting. And there are many dynamics that emanate from the outer setting and that affect how things are done, how decisions are made within the inner setting. So for example, within the VA, we have performance metrics that need to be met. And when we were doing this, there were performance metrics around referring patients to weight loss programs or weight management programs. This person said, it helps us to meet performance measures that we need to meet nationally, that we need to meet. So whether you're within or outside of VA, there are often quality or performance metrics that need to be met, or at least it's better if you do. And leaders are often evaluated based on their ability to meet these metrics. That can be a real advantage if you're able to align your implementation efforts with those goals, with those leadership goals. In this case, again, here's a positive statement that I shared, but then we also had someone on the opposite end of the spectrum. And again, it was the same performance metric, but the other person felt like the new program would undermine their ability to meet performance metrics. So again, same situation from our perspective, because we've kind of got the big picture in mind and are working with multiple sites, but very different perceptions within each of the individual sites. The fifth domain is the process domain. The CFIR is, like I said earlier, a determinate framework. That means it's an explanatory framework. For those of you who are more quantitatively minded, you could view these as potential variables that would moderate the relationship between the strategies that we use to implement and our outcomes that we observe. The CFIR does not prescribe a specific way of doing implementation, but what we did do is draw off of many other approaches for implementation and quality improvement and selected 4 high-level constructs that occur in all of those approaches. One is planning, the second is engaging key stakeholders, and then of course executing, and then reflecting and evaluating, taking the time to monitor progress and then to make adjustments as the implementation progresses. In this case, with respect to engaging, this is an example quote from a physician who said, "I didn't even know that was available to my patients." So this would indicate kind of a poor engaging, that there was very little engaging going on with the providers that we needed to get the referrals from for the program to be successful. There is a dynamic interplay between process, so the activities that we're doing to actually get the work that we're doing to get implementation in place, and the multi-level ripple effects of context. And so I hope I've given you a feel for how the CFIR, a framework like the CFIR, can help you step through systematically these different layers of influences on implementation. And again, going back to our technical assistance website, one of the tools that we have is an interview guide maker. So this helps give a guide, or helps you to develop an interview guide based on the highest priority constructs. So you can either create a guide based on all of the constructs, but most of us don't really have the luxury to explore every construct within the CFIR. So there are methods, which I'm not going to go into right now, but because of lack of time, but we do have some guidance on our technical assistance website to try to reduce the 39 constructs down to maybe a dozen or 15, something that is feasible within the time and constraints related to your project. But we always start with open-ended questions so that themes and influencers or factors or constructs can arise out of arise or emerge naturally out of the data. And then we need to adjust our interview guides to take that into account. But to start off, we can select the domain. So in this case, the inner setting, and then select a construct, and in this case, networks and communications, which is all about the nature and quality of professional connections or relationships between people. And in an environment that has very strong positive networks and connections or communications, you can imagine that it would be an easier and more receptive place within which to do implementation, all other things being equal. So then the interview guide maker tool gives you the ability to check the boxes for questions that you think are good and applicable for your particular project. And you can kind of step through and do this for all of your constructs and then produce the output, and it is formatted for you. You can cut and paste it, put it into Word, and then tailor it from there. You often want to kind of adjust the language for your particular scenario for the people that you're talking to, and also depending on the stage of implementation that you plan to ask these questions. So there are published papers, a couple of published papers that give some good practical guidance on how to select a framework for your project. And these are just a couple of articles along with a website, and these are all freely available. So coming back to our mixed methods study design for our evaluation of barriers and facilitators for TLC implementation, we collected qualitative data using interviews, and I gave some example quotes out of those interviews. We then quantified qualitative data, and we linked it to actual referral rates at the end of the 19 months of the pilot. So I'll talk now about how we quantified qualitative data. So in the case of, let's just say, compatibility as one example, and the question would be, what are the perceptions of how compatible the new TLC program is with clinical processes and pre-existing programs. So this is a quote that is an example of one that reflects a strong barrier. So this person said, our nurses are specifically forbidden to write orders. Everything that gets written has to be written by a physician, and this has formed a really labor-intensive situation for practitioners. We also had many other examples at this particular site. This is not the only quote, it's just a representation. And our analysts applied a -2. So this means that at this facility, there was consistent perception with concrete examples of how they felt that the TLC program was really not compatible with their current clinical situation. And then on the opposite end of the spectrum, I showed earlier, and then here's an example here of a positive quote, a positive facilitating perception of compatibility. So this person said, this really helps the patient to have ownership for their processes and their living, and it definitely blends very nicely with the health coaching that they already had. So when we go through and apply these ratings for every construct that we evaluated, for every medical center that was included in our study, we're able to link the ratings. So on the bottom here in this kind of toothy diagram, it is a bar chart that shows the barriers versus facilitators. And you can see on the left side that there were either weak, so it was either a +1 or a -1 on the left side, but then as we moved to the right, there were more and more strong facilitating scores. And in this case, in the red line at the top is an ordering. It's going from the lowest referral site to the highest referral site. And we can see that there was a correlation of 0.55. This is a very small sample size. So in this case, we said that it was weakly correlated because it was only a p-value of 0.08. But nonetheless, there is some signal here that compatibility is an important consideration. So this tells us that we really need to pay attention to people's perception of compatibility. And there are implementation strategies that can be used to help adapt if needed, to fit in better with the pre-existing clinical conditions, or to leverage the high compatibility in the places where it was a facilitating factor. When we put this all together, this is the whole list, and on the left side in the blue boxes, I listed the 7 constructs that had a relationship with outcomes. So these are the 7 constructs to pay attention to in future implementations. We need to identify strategies that can help to address these potential most commonly occurring barriers when implementing a program like TLC. So in this way, we were able to take a longer list of constructs and really distill it down to 7 different constructs. It just happens to be 7 to explain the difference of the lowest referral, and the highest referral, where there are 7 times more referrals than the lowest. So now I got a question or some guidance. I know that there was some survey or opportunity for input, and I did have a request to include introduction of the expert recommendations for implementing change, or ERIC, implementation strategies. So these are 2 papers that kind of refined. It's a refinement of the original list of ERIC strategies. There are 73 different strategies, and they have different levels of specificity. They include everything from facilitation as a strategy, which is a very holistic and very broad strategy, to very specific strategies like create education materials, which is a more concrete, specific strategy. So it's kind of a mix in that particular list. We worked on a tool. What we wanted to develop was a tool that would link the CIFAR framework, which I just reviewed, to ERIC strategies. So our basic question, we reached out to practitioners and implementation experts to ask them what strategies would they recommend for addressing each of the CIFAR barriers. And that's a whole nother talk in and of itself. So I'm just going to kind of skip over the top here, but this paper, published in Implementation Science, gives all the details of the study methods and results. But in a nutshell, we really did not have a lot of consensus about which strategies to use to address which barriers. It turns out that even though we have lots of constructs within the CIFAR, they're still pretty high level. Like, for example, if there is an issue with engaging leaders, well, there are many different strategies that can be used to better strengthen the commitment of leaders to support an implementation. And their lack of support, it depends on why, or what your assumptions are about why they may not be terribly committed to your implementation project or your implementation goals. So there was a wide variety of recommendations, but we were able to narrow the list down to a shorter list that can be considered for each of the barriers. So once you recognize barriers that need to be addressed within your study, you can use a tool. We've got it on our technical assistance website, and it is an Excel spreadsheet based tool. It's very simple, and there's an embedded macro that allows you to specify the barriers, and then it will output a list of strategies to continue. One of the important things in creating a strategy for implementation is to tailor the strategies for your particular context. So there's a general approach of assessing context and choosing your strategies. But a lot of times it's a little bit of a black box about how exactly do you choose strategies. And I will say that there's increasing guidance, really excellent guidance that is building in the literature, but it is still, there's a lot of art involved and a lot of very kind of specific, thoughtful design that really needs to happen. And the approaches that are used by different projects vary quite widely. Maria Fernandez and colleagues has created, based on the intervention mapping work, so that you can go to interventionmapping.com to get resources and references and guidance about how to design interventions, including implementation strategies for use. Maria Fernandez actually wrote a paper for implementation mapping based on the concepts within intervention mapping. But basically, we need to understand with each individual barrier, what are the objectives or the outcomes that we're trying to achieve. So for example, if networks and communications is really low and it's poor, what is it that we can do? What is it that we want our strategy to do? And so we have to identify those objectives and then match the strategy that can achieve those objectives. And we also, at some level, we need to understand the mechanisms of change, specifically to improving, in this case, networks and communications. So here's a snapshot of the paper that I was referring to earlier. The list of constructs that I showed you coming out of TLC, those constructs can help to guide our entree into implementation mapping. So task one that Fernandez and colleagues lays out is to conduct a needs and assets assessment and to identify adopters and implementers. And in this case, it is identifying barriers and facilitators as well. But when you, well, actually, I'm not going to go there yet. Just give me a minute. But I'm just going to touch on an example. So in our TLC evaluation, we found that networks and communications was really important. 2 ERIC strategies that had a pretty high degree of endorsement and agreement were to promote network weaving, which is a very high level strategy to basically build those relationships. And then a more concrete strategy of organizing implementation teams in team meetings. So basically get people into a room and help them to work together. And this is where facilitation can be helpful, or coaching to help with the team formation and functioning. So now if we add a little bit more to this kind of process of specifying and tailoring implementation strategies, the black box becomes much more clear. We want to create a transparent pathway for how those strategies were chosen, how they are operationalized, and what then the outcomes are, or how effective they were. There's a paper that was written by Anola Proctor and colleagues that talked about recommendations for specifying and reporting. And this particular table in this paper, I find really useful to help guide operationalization of strategies. This is kind of a high level approach, and it's very much aligned with the implementation mapping that I pointed out earlier. But basically, for each of the strategies, we want to know what are the actions, the actors, who are the targets of each of the strategies, when do we apply them, and what dose, what are the expected outcomes, and our justification for that. So basically, what is our theory of change, and why do we think that's a good theory? So the power of theory. I hope that I've demonstrated that at this point, up to this point, that a framework, a determinant framework like the CFR, provides an organizing framework for research studies. It enables us to build the scientific knowledge base, and it provides common terms and definitions. And I think that this value that a framework like the CIFAR brings to the table, this may be the most important contribution. And I have to say that when we first started out with the CIFAR, I did not adequately recognize that value. I didn't realize the power of language and how much really it has contributed to and helped advance theory development and building the knowledge base. And the same can be said again of users of the Paris framework or normalization process theory. There are different communities of researchers who are all using kind of similar theories or similar lenses and frameworks in their work. And it is really essential that they be able to, that we all are able to share our findings and build on, that I can build on your findings and vice versa. So in the spirit of, I always in my talks want to encourage people to critique the CIFAR. We don't have very many papers in the literature that actually come out with recommendations for improving, expanding, deepening the CIFAR. But we are in the midst, our team is in the midst of processing the literature review and then follow-up surveys to corresponding authors. And we have been able to glean quite a few recommendations, actually. Even though the proportion of papers published, the percentage is pretty low for recommendations. But based on the recommendations that we have identified through surveys and through, and also through the literature review, we are working on a version 2 of the CIFAR, where we will center patients more prominently in every domain. So for example, with innovation characteristics domain, we will recommend and highlight the importance of eliciting perceptions from patients, as well as other key stakeholders. And we really see two groups of kind of key stakeholders. I'm using the stakeholder term kind of broadly. One are the people who are involved are actually three. The people who are involved in implementation. And more research teams and implementation teams are really seeing and understanding the importance of involving patients in implementation. So patients can play that role in implementation. The second kind of major group of people to consider are the people who will be delivering the intervention. So the CIFAR was designed within a clinical setting, and we have providers and staff who are responsible or have roles for effectively delivering the innovation to patients, to their patients. And then the third major category of individuals are the patients who receive the benefits or receive the treatment, receive the innovation. And that latter group are really outside the purview of the CIFAR because they are considered as part of kind of the innovation, the outcomes from the innovation themselves. But they're all interrelated. So the more we're able to include patients up front in a role of implementation, the better situated, the better positioned we'll be to effectively deliver and adapt the innovation and the implementation strategies so that we can maximize benefits for patients. Within the outer setting, we are adding several new constructs, one of which is community characteristics, where we will include concepts related to social determinants of health, the built environment, discrimination, racism, We will also include other constructs as well, which I'll get into a few of them later, but those that are related to patients. Within the inner setting, we're going to include patient-centered culture. Within individual characteristics, we will explicitly recognize the important role of patients, as I was saying earlier. And then within process, we will recognize the importance of engaging patients, and that patients help to inform our adaptation, our planning, and our reflecting and evaluating about how things are going. In the process domain, within executing or within the process domain, we will recognize the importance of teaming, bringing in concepts from Amy Edmondson, of adapting, of piloting, and doing iterative cycles of change rather than trying to do everything all at once necessarily. Okay, within the outer setting, additional constructs. So I already mentioned community characteristics and then needs and resources. It will still be patient needs and resources, but really kind of looking at the population prevalence and demographics and also qualitative data as well. We're also recognizing, I mean, being in the middle of a COVID-19 pandemic and Delta variants and so forth, just recognizing the key role of mass disruptions. And we will have a code specifically for that. And these may include wildfires, flooding, pandemics, other just unanticipated global, regional disruptions that affect our implementation efforts. We're going to add partnerships and connections. Actually, this is a renaming as is market forces. And I can get more into that if you have questions about that later. We had a construct called external policy and incentives, and which was kind of a catch-all kitchen sink kind of construct because we didn't have a lot to go on when we first developed the CFR. But now we're going to explicate this much better and recognize the important role of laws and regulations, funding sources, practice guidelines, and performance goals and public reporting. We will also add a CFR outcomes addendum. And we are doing this because a lot of users gave input about, well, they literally recommended that we add an outcomes domain to the CFR. But we didn't want to add a sixth domain, and instead we have a guiding addendum about conceptualizing outcomes and the importance of conceptualizing outcomes. So the first thing to recognize is that the CFR is a framework of determinants. So in other words, moderators or potential predictors of outcomes. And that is the role of the CFR. And those are contextual determinants. And then those may predict or influence what we're calling perceived or perceptual implementation outcomes. And these include concepts of adaptability, implementability, and sustainability. And for those of you familiar with the LeaRRn framework, you will recognize those three types of outcomes. And then those perceived outcomes may help to predict future observable implementation outcomes, including actual adoption, implementation, and sustainment. And then in turn, those would impact innovation outcomes or innovation impact. And we are strongly recognizing the importance of three major classes of outcomes or recipients of those outcomes. One is the employee. So there's the triple aim within healthcare that talks about the importance of quality, safety, cost. There's a fourth now that has been added to include providers, and we broaden that still further to include all employees. It is really important that what we implement improves the experience of the employees that are delivering. And we want to assess employee experience indicators like burnout, teamness, etc. Then there are system outcomes and patient outcomes. If we are able to track and kind of communicate and achieve outcomes for these three major categories of individuals, then we'll have a much better chance for sustainment. And I think a key theme across this outcomes addendum is the importance of considering sustainability that would hopefully lead to actual sustainment. And this was a question that I also received from the group, and that is, how can we, in my own work, we have such a focus, and I think this is true for implementation science as a whole, that we have such a focus on achieving what I'll call shorter term implementation goals. And a lot of times we have a specific window that we're funded for, and then we go on to the next project. But what happens when we leave? A lot of times, even if we achieve our implementation goals, like at 6 months or 12 months, when the funding and the support is pulled and moved on to something else, then oftentimes we lose the gains that we had. And so we're focusing, our own team is focusing more and more on how can we get the longer term sustainment, so that even after we pull our team, our support, that the clinic is able to carry on and really and truly routinize that innovation into, this is the way we do it. And that takes, that's really more of a long haul. So how do we move? How do we address perceptions of sustainability and then ultimately future sustainment or true embedded institutionalization? We often think about, or we should, I think about implementation as kind of phases. One is that a lot of effort and attention has been spent on initial implementation. So we give facilitation support. We identify champions who are actively implementing. And then, like I said, the spotlight may go away and work on something else. But that initial implementation period, a lot can be achieved and has been achieved. But where the real challenge comes in is, how can we keep those teams engaged in ongoing implementation and fit of the innovation to the clinical setting so that we can have sustained positive impact. In our work across several different studies of barriers and facilitators, we get repeated occurrence of constructs. Networks and communications, how do people work together? Compatibility of the innovation with the clinical setting, leadership engagement, available resources, and a big gap in process that all too often people use what I call the hero model of implementation, where there's one person, one champion who is really dedicated and enthusiastic and committed to making implementation goals. But then if she gets another position, or she leaves the organization, or she's forced to work on something else, everything can fall apart because it was based on that one person. So how do we get it to more of a team setting and engagement and functioning, and then out to, again, providers delivering the innovation as a part of routine care? So one framework that we've been working with in addition to the LeaRRn is the dynamic sustainability framework, which states that really for increasingly better fit, we really need to engage teams in plan, do, study, act cycles of change over the long term. In quality improvement words, we need to engage frontline teams in quality improvement using cycles, iterative, small cycles of change. In implementation science terms, we need to engage teams in continuous optimization of new treatments and programs, et cetera, to really, truly embed those programs for sustained use. So this is coming out in a theoretical framework. It is also coming out in a deep ethnographic study where, again, this particular study concluded that cycles of change, cycles of learning were needed beyond just the initial implementation. And when you put this all together, so we've got implementation science, we've got empirical evidence, synthesized empirical evidence, we have quality improvement theories and methods, we have theories of learning health systems, the importance of learning loops at the micro and macro level within the organization. And there also is the high reliability organization that some of you may be involved in. Every one of these has at its heart, at some level, a pillar or a principle, or at the heart or the core, engaging teams in cycles of plan, do, study, act, or some level of engagement in continuous improvement. Our own team has created a program called the LEAP program, which is hands-on learning, coaching within busy clinical settings. We provide coaching, virtual learning, there's no travel required, linking in with actionable data. 49 teams have participated so far. We have measures of increased skills, QI skills, and application, high satisfaction, and high intent to continue working as a team. And then we also have testimonials. So this is getting into a much more fluid, but imagine if you as an implementation or an implementer came into a clinical setting where you already have high functioning teams who are engaged in small cycles of improvements, how much easier your life would be implementing a new program, because they would already have the skills and be working together as well. So all this to say that embracing complexity is incredibly important. And I think I've talked about intervention complexity, contextual, and implementation complexity. And I've also touched on pathway complexity as well. So with that, I want to open it up for discussion. And thank you again for the opportunity to talk with you.